The Masterka is a pushed, self-retaining monocanalicular stent for nasolacrimal duct intubation used to treat congenital lacrimal duct obstruction in patients 12 months and older. The Masterka has a metal introducer located in the lumen of a silicone stent. The introducer is not an extension of the silicone stent as seen in more conventional type stents. The introducer facilitates insertion of the stent and is completely removed once intubation of the lacrimal passage has been completed. The Masterka has a self-retaining punctal plug to allow for fixation and easy removal. The Masterka comes in 3 lengths, 30, 35, and 40 millimeters, and is provided sterile, 1 per box. It requires use of the disposable sizer, provided sterile, 5 per box. The procedure is very similar to placing traditional stents, but the Masterka is much quicker, simpler, and causes less trauma. The surgeon begins by probing first with a Bowman probe, then with the disposable sizer. Confirm that the stenosis is simple, located at the valve of Hasner, as complex stenosis is contraindicated. Confirm metal-to-metal contact in the nose, ensuring a false passage has not been created. Keep the disposable sizer in place and use it to measure for the appropriate length Masterka. There are 5 identifiable markings on the disposable sizer. The 3 marks nearest the white end cap of the sizer are at 30, 35, and 40 millimeters for use with the Masterka. The 2 markings closest to the distal tip of the sizer are for use with the SRS-2 and will not be used with the Masterka. It's important to point this out in advance so that there is no confusion. While in the nose, identify the sizer marking that is at the punctal opening as being the 30, 35, or 40 millimeter mark. This will dictate the appropriate length Masterka to use for this patient. In other words, if 2 markings are visible on the sizer, the third is not visible, use a 30 millimeter Masterka. If only 1 marking on the sizer is visible, the other 2 are not visible, use a 35 millimeter Masterka. And if there are no markings visible on the sizer, use a 40 millimeter Masterka. The sizer is then removed, and one pearl to suggest at this point is for the surgeon to partially remove the metal introducer from the Masterka stent and lightly lubricate the introducer to facilitate its easy removal separation from the stent. Once lubricated, push the introducer back into place in the stent. The sterile Masterka is inserted through a dilated punctum into the canaliculus. Rotate the stent 90 degrees and push the stent into the nasolacrimal duct until the plug comes in contact with the punctum. The surgeon should verify proper placement of the stent endoscopically prior to removing the introducer from the stent. If not using an endoscope, gently confirm metal-to-metal contact in the nose. Using the dilator end of the green plug inserter, firmly hold the plug in contact with the punctum during removal of the metal introducer. Make sure to pull the introducer out along the main axis of the lacrimal duct. Remove the introducer by twisting it back and forth, similar to winding a watch. Seat the plug in the punctum using the metal tip of the green punctum plug inserter. In other words, engage the plug of the Masterka on the green inserter, push the Masterka plug into the punctum, and once seated, release it from the inserter by squeezing and holding the inserter as it is withdrawn. If you release the squeeze, it will cause the inserter to re-engage the plug and pull the stent out. It is common for a surgeon to use the dilator end of the inserter to seat the plug as well, as it seats very easily. The plug should rest flush with the lid margin. The stent should hang freely in the nose. It has been reported that from the time a young patient is taken from the parents to the OR, masked, procedure performed, patient awakened and returned to the parents, takes only about 15 to 20 minutes. Parents love this surgical scenario because the child is not under general anesthesia or even laryngeal intubation, which causes a sore throat, and there is less trauma and pain associated with insertion of the stent.